Hi, my name is Sundar Sad. I'm a family and community physician, women's health specialist, and today's talk is Introduction to Menopause. This presentation is part of a series of presentations on women's health issues on the Repronet channel. Repronet network is a network based in California to cater and serve the health of refugees and immigrants in the States. Repronet is led by Dr. Heike Thiel, and I'm deeply grateful for her and her team for bringing such service to the community. Our talk will focus on explaining some terminologies and words that we use regarding menopause health, symptoms and signs of perimenopause and menopause transition, the impact and the significance of that transition, some messages and means that women can actually benefit from in order to optimize their health outcomes, and how can we move and transition from reproduction to reflection. Women's health is the branch of medicine that focuses on the treatment and diagnosis of disease and conditions that affect a woman's physical and emotional well being. It's basically the effect of gender on disease and health. Some terms you actually may notice or hear from your physicians when you have encounters related to women's health is the natural menopause, spontaneous cessation of your menstrual periods for 12 months after 40 years of age. We consider that naturally occurring. It can be induced if you had surgery where your ovaries or your uterus have been removed, or you've had chemotherapy that led to early or premature ovarian damage. Premature menopause is one that happens before age 40, cessation of your menstrual period before you are 40 years of age. Primary ovarian insufficiency is one where ovaries are not functioning, where there's no periods or no menstrual flow in women younger than age 40. Um, the perimenopause, it's the period of time that used to be called climacteric, and we don't use that term anymore. It begins with the onset of changes in your cycle, plus minus 7 days. So if your cycle was like 28 days and it has become 35 days or more, or 21 days or less, that is menopause related symptoms. And it extends beyond the last menstrual period to include the 12 months after menopause. Thus, it lasts at least 1 year longer than the menopause transition. And oftentimes, that's where most women may experience perimenopause or menopausal transition symptoms. Menopause transition is the span of time that begins with the onset of menstrual cycle irregularities and extends through the final menopause period. So it doesn't really extend a full year after your last menstrual period. And that's the difference between the menopause transition, which is like you moving in to the last menstrual period, and the perimenopause extends to the 1 year after menopause. And the reason we have both and we kind of look at them differently is that the health impact of that 1 year after the last menstrual period is significant. And oftentimes it's a retrospective diagnosis, meaning we cannot diagnose that until you have had your last menstrual period and that year have passed. The final menstrual period is the one period where it's followed by 12 consecutive months back to back of no menstrual bleeding or any kind of vaginal bleeding. Postmenopausal is that you've had no menses for 12 consecutive months. That's when we call a woman postmenopausal. Genitourinary syndrome of menopause. It's one that a constellation of symptoms, group of symptoms that impacts the vulvovaginal tissue and the pelvic floor, and it has replaced the outdated term atrophic vaginitis or vaginal atrophy. Perimenopausal prodromes. Up to 35, most women would be called premenopausal, or for as long as you have regular periods, you're more likely to be considered premenopausal. Once you start noticing some mild irregularities in your menstrual period, we are talking about perimenopausal transition. Once you have moved to the last menstrual period and you moved into the menopause with 12 months, that will be considered postmenopausal. These are the stages of menopause throughout a woman's life. The average expected to have your menopause, which is last menstrual period, is 48 to 51 years of age. At least that's what we know to the moment. Anything younger than 40 is considered premature, and it merits discussing some of these symptoms with your doctor or primary care clinician. Specialties that may encounter in the process of diagnosing menopausal syndromes or discussing health education for menopausal symptoms could be your obstetrician, gynecologist, endocrinologist, fertility and reproductive health, functional and integrative medicine, as well as primary care including family, community medicine, and internal medicine. Menopausal changes can happen um, at the ovary level. So, if I put in an ultrasound for a woman, for instance, we may notice that the ovary size have changed from being at least 2 by 2 centimeters on the ultrasound, or having like active follicles and eggs production, to one that looks like a thin streak or thread, or even not visible on an ultrasound. So, that's an ultrasonic changes that we notice if a woman gets a pelvic ultrasound. Other changes when we are younger, the progesterone is higher because the progesterone is a progestation hormone, meaning it one that increases chances of women of stabilizing a pregnancy. That is why the younger we are, progesterone is a bit higher than the estrogen. And then as we move to our 30s, there's like more of an increase in the estrogen compared to the progesterone, because the estrogen helps strengthen your heart muscles as well as your bones. And we need that in order to kind of do the role potentially meant naturally for women who may have had babies or are doing breastfeeding. And then as we move towards our end of 40s into our fifth decade, we actually notice that the estrogen, progesterone, both of them go lower. And with that, sometimes women may not necessarily notice that their estrogen receptors or progesterone receptors are actually getting lower. And that is why some women may experience menopausal symptoms and others may not. At the tissue level, for instance, in the uterus and the vaginal area, women who have adequate estrogen progesterone, they will have puffy, thick, and healthy tissue in the pelvic floor, in the vaginal area. However, once this gets less and less, as you may notice, things become thinner, and that predisposes women to bladder infections, vaginal dryness, pelvic floor weakness. Other things to keep in mind is that the estrogen has its own benefits, and it's also not just a sex hormone. It has receptors in the brain, the breasts, ovaries, uterus, skin, bones, liver, and heart, and many others that we are still learning about. So, in the heart, the estrogen protects us from heart attacks. That's why women are less likely to experience heart disease in younger ages. It also has cholesterol production regulation from the liver. It also gives us bone density and strength, also does anti-aging effect to the skin by maintaining collagen levels. In the brain, it maintains body temperature, improves memory function, and adjusts the sex drive. In the breasts, it kind of tends to stimulate breast growth and feeding function. For ovaries, it kind of keeps the maturation stimulation to bring an egg to mature enough for fertilization, as well as prepares our uterus for monthly menstrual cycle by thickening the endometrial lining. The progesterone effects, on the other side, is a stabilizer of the uterine lining. That is why there are some intrauterine devices that we use that are progesterone laden that can help us stabilize the lining. It helps us also use the fat for energy. It is a natural antidepressant, and it does facilitate the thyroid hormone function. It does normalize blood clotting, so reduces the potential for that risk. It also restores sex drive in order to increase chances of conception and pregnancy for women who are producing eggs, regulates blood sugar in general, and protects us from endometrial cancer. And it does have a probable prevention of breast cancer at the natural progesterone level. The impact of menopause, it can increase cholesterol. So once we transition to menopause, meaning the cessation of the period, our cholesterol can actually increase. We may experience what we call vasomotor syndrome of menopause, which is hot flashes, also bone thinning. We won't be able to get pregnant naturally or biologically, since there is a cessation of producing eggs as well. Some women may report mood changes, slow digestion, and sleep disturbances. As you can see here, there are significant impact due to the receptors of the progesterone and estrogen not necessarily following the decline. Meaning, if I have estrogen lowering, the estrogen receptors in the brain, the hair, nail, and skin, they continue to be produced at a higher level than the estrogen available in the body. And that mismatch in the reception versus the supply, that sometimes makes some women more prone to experiencing menopausal symptoms. This might be a little bit of a complicated table, but the idea from it is as we are having regular periods, we are most likely in the reproductive phase, meaning we are still producing eggs and we can conceive naturally until we start noticing some subtle changes in the flow or the length of the periods. During that time, we may notice some hormonal changes. So your doctors may opt to check some hormones like follicle stimulating hormone known as FSH or AMH to check your ovarian function or some other hormones, or even do a pelvic ultrasound if the bleeding is abnormal. Once you start noticing that there's plus minus 7 days, as aforementioned, that means you have transitioned to the perimenopause. A common question that women ask: how long will I stay in that period of time? Once you have had more than 2 months in between your cycles, most likely you will be around that transitional period between 1 to 3 years. And then past that, you may experience a 1 year full postmenopausal, and then another year that you are just transitioning to the idea that I'm fully postmenopausal because you have earned that diagnosis in hindsight. Significance of this transition is that women would struggle with the periods being irregular, and that might actually be concerning for, am I pregnant, is there anything going on, and they might actually go through a lot of testing to figure out if there are other reasons to what we call abnormal uterine bleeding or dysfunctional uterine bleeding. And then another thing is that it's in retrospect, meaning there is no period for 12 months. And that year is very critical. If you have had the adequate education, then that's when you start making some lifestyle changes before the major changes as decrease in bone density or decrease in estrogen level or increase in cholesterol happens. Another important thing to remember is that at least 1/3 to a half of women's life is spent in postmenopausal period, especially for women who enters that period of time around 40. And the life expectancy of women in America is between 81 and 82 years of age. Ovarian aging does not necessarily go with the woman's chronological age. So it doesn't matter. You could be 51 years old and still getting regular periods, and your ovarian age is pretty much younger than a woman who's 40 and passed through the transition. A lot of times women would graduate to OBGYN. So they have either done with their pregnancies or their breastfeeding, and they're not necessarily seeing their OBGYN. And then they fail to follow on a yearly basis with a primary care physician in order to get the necessary health education or coaching regarding their transition. Another thing is that gradually, and it varies from a woman to the other. So 50% of women do not necessarily experience any menopause symptoms, and 30% of women may experience some transition, but it's usually transient and temporary, and they will graduate these symptoms afterwards in 1 to 5 years. That is why it's very important to discuss if you need treatment that is temporary to relieve your symptoms, or you want to just follow the lifestyle prescription and monitor. And there are 20% actually of women who continue to experience menopausal syndrome or menopausal symptoms till the end of their lifetime. And those may require long-term treatment. Osteoporosis and limited fertility because of the menstrual changes are very specific to women and more likely to happen in females. Alzheimer's disease is 17 times more likely to happen in women, and it seems to be happening mostly in postmenopausal women who have a larger life expectancy. And there are definitely some genetic predisposition, but we are still studying the relationship between menopause and Alzheimer's disease. At least 6,000 women enter the menopause daily, and more than 50 million enter that on an annual basis. What does menopause try to tell us? We are aging, and we can choose if we want to grow up or grow old. There is certainly loss of biological fertility. There are sleep disturbances. Sometimes it's called WASO, or waking up after sleep onset. We notice that most women report that I can't stay asleep even if I can easily initiate sleep, and that seems to be more specific to menopausal transition. There are health conditions or chronic illnesses that may accompany this transition due to the changes in metabolic profile, as in cholesterol and fat distribution. There are some who experience change in social status because of the moodiness and the mood changes that may go undiagnosed or unhelped or unassisted. So there are up to 60% of women who report changing in their marital status during the menopause transition, unfortunately. There's the phenomenon called emptiness. So women, they kind of salute their kids goodbye because they are growing and leaving the home. And some experience something called sandwich generation due to the industrialized nature of our living. So we may actually be taking care of our parents as well as taking care of our kids. And that leads to a caregiver burden to many women who are going through the transition. A lot of times women report like seeking self identity as well. So that who am I and how is this change going to impact me as a person? So we usually recommend you use some of these means. Invest in today. So make sure that you start today in lifestyle changes in order to prepare yourself. No matter how young you are, make sure that you prepare yourself for that transition today, even if you are 18 years of age. Healthy daily routines. It's really the consistency of the sustainable and healthy changes that you can do, even if minute. If you can do those on a consistent basis, you will notice a difference over the years. We do recommend that you get to see a primary care physician, establish a rapport with one that you are comfortable with, and at least visit them every 1 to 2 years. Even if you don't have acute illnesses, it's really good to get health coaching and education and make your annual about prevention rather than treatment. Try or consider volunteering in extracurricular activities. So build your village brick by brick and be part of a community. Self reflection and setting social boundaries. It helps a lot actually to know what your limitations are, delegate tasks, especially if you are experiencing the sandwich generation component. So make sure that you're not doing everything for everyone. Work on life goals from this moment and try to share those with your physician so they can outsource you and help you with resources that are known to be safe and evidence based. Management. It's very important to know how to handle menopausal syndrome or menopausal symptoms. Validation and reassurance. A lot of times women experience invalidation in their symptoms, like, oh, it's okay, like it will pass. A lot of people may not necessarily experience this, or, I haven't experienced any menopausal symptoms. You will be just fine. So it's very important not to deny or to dismiss people's symptoms, and especially in regard to that transition. Lifestyle prescriptions. Since we will stop bleeding, I would always recommend a plant based diet. So focus on your green leafy vegetables, try to increase proteins from plant sources, focus on healthy fats, your olive oil, your organic butters, your pumpkin seeds, and seafood, things that would actually help restore some of these hormones since they are mainly made from healthy fats as well. CBTI stands for Cognitive Behavioral Therapy for Insomnia. It's the first line therapy for women who experience sleep disturbances. So we highly recommend you discuss that option with your physician as well. Some women may actually require medications, and there are plenty that are evidence based and safe for eligible candidates. So please do not shy away from using medications, especially if the transition is significantly impacting your lifestyle. Disease risk reduction. So things that can increase like high cholesterol or heart disease can be modified by weight management, can be modified by blood pressure management or paying attention to your cholesterol and liver health. So it's very important to discuss those annual and screenings in your annual and preventive visits. Cancer now is considered a chronic disease, so it's very important to discuss the most up to date screening and preventive screenings, secondary and tertiary ones, for cancers that may be more common in women, and we will come to that in a second. For women who are experiencing the brain fog or changes in mental health, I would recommend cognitive screenings either through PHQ-9, which is for depression screening, or ADHD or anxiety screening, or even mini mental status. So whatever changes in your cognition or ability to focus, these are things to bring in to your physician to do the proper and evidence-based screening. Lifestyle directives, as I've aforementioned, balanced diet is very important, and it will help a lot of women actually avoid the waistline weight and the belly as you may be seeing on social media sometimes. Dental care is very important. It's the bone that you want to take with you to the next world. That's what I usually tell my patients. So it's very important to make sure that you uh, kind of brush and floss every day, and you have done your dental exam, dental checkup every 6 months, and you have difficulty access to care, make sure that you ask your physician or even search for free clinics around to get your teeth taken care of. Try to avoid all forms of addiction, alcohol, drugs, smoking, caffeine, high sugar intake. All of these things could be actually forms of food addiction. Would recommend that you discuss that with your physician in order to remove that, and try to build a plan on a gradual basis to improve that potential. Vitamin D, 1,000 to 2,000 units. We recommend that on a daily basis, plus calcium, preferably from dietary ingredients, so either green leafy vegetables or dairy products. Make sure that you go out in the sun using sunscreen and maintain a healthy weight. Your exercise has to change to an extent to where you include some cardio, meaning heart health exercises like aerobics or swimming, and weightlifting and muscle mass building, because we lose a lot of muscle mass during the first year postmenopausally. Manage stress as much as potentially possible and talk to your doctor about that while you're building your village in order to make sure that your relationships are supportive of your mental health. Preventive screenings that we recommend are blood pressure, bone density, lipid profile, breast cancer screening, pap tests, and blood sugar, and colon cancer screening as well. The breast cancer has changed just in 2024. We recommend that women do mammograms at age 40 years of age every 2 years, and your cholesterol levels, if you don't have any issues or diseases, you do that every 3 years. The DIXA scan for all postmenopausal women based on risk factors, but the current guidelines is to do them for women 65 years of age or that who are 10 years postmenopausally. The blood sugar is one that you do every 3 years through either a fasting blood glucose or an A1C. The colon cancer screening for people who do not have risk factors is either a FIT test, which is a stool test, or a colonoscopy for women older than 50 years of age. How can we actually manage menopause? It depends on the severity of symptoms and how old is a woman, and does she have a uterus or not, and if there are any chronic diseases that are genetic or personal, social or behavioral habits. All of these things would actually make a difference in how we manage or decide to intervene. Most of the time, lifestyle prescription would do the great job, but the younger the woman is, or the more chronic diseases that we have, we probably need to talk more about medication intervention. Societal factors, the cultures that we come from, would actually impact our choices of medical treatment. A lot of times, unfortunately, medicine is commercialized, especially for women's health. So, a lot of times, women have done doctor shopping or relied a lot on traditional or folk medicine. There's not much research on women's health, and there's a focus on fertility and conventional standards of beauty, which can really delay the talk to the doctor or that important conversation, or deny women access to evidence-based care or medical management. So I highly recommend you talk to your doctor as soon as you feel that this is a question that you seek answers for. We do have some evidence, and we actually appreciate women utilizing that to serve them best. For women who have moderate to severe symptoms of menopause, we actually may recommend hormonal modalities or hormonal treatments. So for women who experience genitourinary syndrome of menopause, we may recommend topical estrogen or topical treatments, as in Entrarosa, or like basically androgenic hormones or like steroidal hormones. We do recommend that for women with GSM. We may recommend systematic hormonal therapy, especially for women who are younger in age or experience significant hot flashes known as vasomotor syndrome of menopause, and women who are at risk of osteoporosis and they are younger, experiencing menopause younger than 45 years of age. We may recommend estrogen and progesterone therapy depending on the presence of a uterus. Some women actually who are younger now, there is a research for ovarian transplant, but that is not yet out there in the market, but it's an exciting development in women's health. Non-hormonal modalities that we use. Definitely for sleep disturbances, first-line therapy is cognitive behavioral therapy. Insomnia, you can be referred to a counselor or a behavioral therapist to discuss the tools and sleep hygiene kit that women could significantly improve their quality of life and longevity if they were to have quality of sleep. Nutritional counseling is a pillar of menopause transition. We cannot continue to eat the same way we used to eat when we were 20s as we are transitioning to menopause. So it's very important to discuss your nutrition and your diet with your physician. Topical lubricants doesn't have to be necessarily estrogen based, so there are hyaluronic acid and other options that women can use topically for genitourinary syndrome of menopause. Other options that are evidence based are neurotropic. We call them in the past antidepressants, but these are medications that could actually enhance the cognitive function, reduce the potential for depression around menopause, as well as an anxiety medications, and can improve also the sleep disturbances. Hypnotics is also another option that women can use as non hormonal modality. What do I want you ladies to remember? A woman's age does not necessarily mean that her ovarian age will go along. So you could be young and still ovaries are retiring early, and you could be older than the average age and your ovaries are still functioning at the clock. Menopause is gradual and it's a huge part of a woman's life. We definitely require an active patient participation in order to make and optimize health outcomes for women. There are effective and safe treatments for menopausal symptoms. We do recommend that you all engage in a culture of healing and participate in scientific research like our project at Repronet. And hormonal treatment is evidence based, effective for eligible candidates. Do not shy away if you are an eligible candidate from discussing that option with your physician. Thank you so much.